back to our second plenary session of the three-day conference. We are going to focus in this session on digital transformation and artificial intelligence, very much a hot topic in every sphere at the moment. Before I introduce our moderator for this session, I just wanted to answer a question that was asked by somebody this morning who said, how many people are actually at escaide this week? And I can tell you that we have 800 people here with us in the conference center in Barcelona and a staggering 2,700 joining us online. So to those of you who are with us online, it is great to have you with us. To the many hundreds of you who are in the room, it is doubly great to have you with us as well. So another reminder before I hand over to our moderators for this session, if you want to ask a question or make a comment, please do. Interaction is what it's all about, as Andrea and Mike said this morning. But please, a big plea, questions in the question box, comments in the chat, and please be as brief as possible. Lots of you this morning writing very interesting but slightly long essays. It's quite hard for me to capture at a glance what your question is. If you can tag the speaker you want to ask the question to, that is even better. And we are using slido.com for the polls, but you can access that through the platform. So for this session, I'm delighted to hand over to escaide Scientific Committee members, the chair of that committee, and the ECDC's chief scientist, of course, Mike Catchpole, and joining us online, Chikwe Ihekweazu, who is Assistant Director General, Health Emergency Intelligence at the World Health Organization. Great to see you, Chikwe. I'm going to hand over to you and to Mike to kick us off.
Jackie, thank you very much and welcome to this session. I can't do it sitting down. So you can't fail to have noticed that artificial intelligence has been grabbing the headlines in recent months. And probably those headlines have expressed in roughly equal measures excitement and concern. And in today's plenary, we want to explore a bit both sides of those arguments. Of course, AI is not new. Artificial intelligence is not new. But I would suggest that the availability of these large language models, such as ChatGPT, has actually provided access to AI to many people that have never had it before, and it's really opened up the discussion. So today, we're going to hear about how AI has been used for some time now in clinical and in public health practice, and what impact it could have on our work in the future. But also, we're going to consider the checks and balances that could or should be applied in the use of AI, and what we, as public health practitioners, what knowledge, what skills we need in order to be able to use it effectively. Now, I'm delighted to say we've got two amazing speakers for you for this session. I'm going to introduce them just briefly both now, and then Chikwe will follow on and we'll start the presentations. But we have, our first presenter today will be Professor John Brownstein. I'm sure many of you will know John. He's Professor of Biomedical Informatics at Harvard Medical School and the Chief Innovation Officer at Boston Children's Hospital. And as well as that, he directs the Computational Epidemiology Lab and the Innovation and Digital Health Accelerator at Boston Children's Hospital. And he's had many senior advisory roles advising the White House, WHO, CDC, and has received some prestigious awards for his translational work in strengthening public health and public health surveillance. So John, it's great to have you with us. Our other guest is equally distinguished and sitting here with me on the stage. Dr. Joanna Goodey. Jo is Head of Research for Justice, Digital and Migration at the European Agency for Fundamental Rights, which is based in Vienna. There she's responsible for overseeing the agency's research and its activities in the field of artificial intelligence. And particularly, she was a member of the European Commission's high-level group on artificial intelligence, and also was chair of the EU agency's network on scientific advice. And prior to all of that, she's worked for the United Nations and had lectureships in criminology and criminal justice. So, Jo, warm welcome to you also. And with that, Chikwe, I hand over to you. No, I don't. No, I don't. That was nearly smooth, wasn't it? That was nearly smooth. So, sorry, Chikwe, I didn't mean to give you a heart attack. So no, before we do that, I've got some work for you. Slido. Can we have the Slido up, please? If you can get your Slido going. We've got 3 questions for you, which we really were interested to know, from your experience and what you know, 3 questions. So the first of those, is artificial intelligence a game changer for public health and surveillance? Very simple. Yes, no. Please, start answering. 42. 42 is the answer. No, 52. 57. Come on, more. Because we've got 2 more questions and we want to get onto the talks as well. I know we got to over 160, 170. Oh, look at this, fantastic. Now we know there are around 800 here and 2,000, was it 700 online? So we've not got to 10% yet, but we won't go for much further. But okay, I think that will give us a flavor. Can we see the answer to the first question? So 79%, almost 80% say yes, it's a game changer. Good, that's a good start. So next question, please. If it's a game changer, do we have enough training and knowledge to confidently use AI in your work? Again, yes, no. Wow, fast off the mark with this one. 300, that sounds like a good number. Can we see what the results are for that? Ooh, nearly 90% the answer is no. So I guess you're all hoping to learn a lot this afternoon. Last question, please. I mentioned there's equal measures of excitement and concern. Are the governance mechanisms and safeguards for artificial intelligence in public health robust and up to date? Again, yes, no, please. Okay, we've got over the 300. Can we see the answers, please? Ooh, 95% saying no. The governance mechanism safeguards are not robust and up to date. So that's a great starting point for today's presentations. And now, Chikwe, I really think I can hand over to you. So Chikwe, please, the floor is yours.
Thanks, Mike. It's been absolutely an incredible experience working up to this time with you, but also working with you for 20 years, from our first conference, before it was called Escaide, up to today. 2003, I think, went for the first conference together with you. So thanks, great working with you on this. So, John, great to have you. The intros have been done. I mean, you built a career around digital epidemiology and pushed it into the clinics and how we understand decision making at the clinical level. AI, the opportunities it presents must really open up a whole new spectrum of opportunities. And just an extra point for colleagues, if you haven't read the article, Advances in Artificial Intelligence for Infectious Disease Surveillance, everyone in this conference should have read that article in NEJM in April this year. So John, let me pass it to you. You saw the answers of the poll. Very interesting. Love to hear your comments, and also look forward to your presentation. Let me pass it to you. Over to you, John.
Great. Well, thank you so much, Chikwe, Michael. Thank you so much for having me present today. I wish I could be there with you, but I'm here virtually, and great to talk a bit about AI. Very interesting to see the responses. Yes, I also believe AI is a game changer, but I actually believe, and we'll have a discussion, that we do know enough to get started. And this is where sometimes I feel that public health often gets left behind a little bit when it comes to emerging technologies. AI has actually been part of the fabric of healthcare and public health for many years, yet I think sometimes we are slow as part of our organization of public health efforts, whether academic or government or industry, to get going in this space. And so I'll talk a little bit about the fact that we already are using AI in many parts of healthcare already. We're using it to reduce burden. We're using it to collect information that through the conversations that happen between providers and patients. We're using it to improve efficiency and reduce the tasks that often weigh down our public health and healthcare environments. I also sit as Chief Innovation Officer at a hospital, and we're seeing the massive rise of these technologies in reducing costs, helping the back end of healthcare do what it's meant to do, which is take care of patients. And so what's interesting is that we're seeing this rise in the adoption of these tools like generative AI, but like, basic even automation is being used to facilitate the practice of care. Yet oftentimes what we're seeing is the value also exists in global and public health, yet we're not seeing the same level of adoption, or at least the speed of pace of adoption. And we recognize that public health could benefit from generative AI in a variety of areas. We've been thinking about where the pain points exist, and I'm sure everyone in this audience can think of dozens of pain points that they are involved in on a day-to-day basis. Think about the time-consuming tasks of collecting data, merging files, producing reports. All the automation that is needed in the practice of public health can leverage the existing technologies that are being made available. Obviously, we are dealing with large amounts of information, large data sets, translating text, putting out public communications. The list goes on of the tasks that are required in public health and in the administration of public health that could benefit from these tools. So what we've seen is, of course, there's an opportunity, and I actually be very curious from the audience how many people are using these tools in their day-to-day. Clearly, out-of-the-box tools like ChatGPT or Bard cannot be used for instance, patient-level data, and we need HIPAA-compliant tools that are actually protected in terms of how that data is administered inside these large language models. And the reality is, AI is not new in public health. Chikwe, thank you for mentioning the paper that we published. We actually did a review recently on what role AI would play in hypothetical respiratory virus outbreak. And we actually have the tools, and many of these tools are already existing, right? The idea that you can use AI to find early insights about a disease event in a population, how you can use AI to organize the content, all the various disparate data sources to produce a risk assessment, how you can improve disease surveillance in resource-poor settings by bringing in better automation and new data sources. And this can range from early symptom identification all the way to understanding the implications of interventions. And COVID truly was a test ground for some of these new methods, where much of these new data sources, these new methods were used to actually improve our ability to actually identify events early, but also provide situational awareness. Again, as we heard, the idea is that, of course, these tools we think are new in some ways, but in fact, they've been applied for many, many years. The idea that you could organize the world's content about disease events and produce surveillance that is actually helpful in a response. One of those areas is in digital epidemiology, which Chikwe mentioned as an area that we've been focused on. This idea that we could tap into what we call the digital exhaust, people's interactions with technology, search algorithms, what they post on X or on Facebook, or what their devices are saying about them. And we've recognized that if you use machine learning to organize and categorize that information, you can get meaningful health data across these massive data sets that could actually be supportive for public health. And so our view has always been, if you can organize all this content and make it available across geographies and time, you could get early insights about disease events in populations. Again, this is not new AI technology. This is tools that have been used for the last 15 years. They were used around H1N1, Zika, Ebola events, all used to help supplement traditional surveillance, and all driven by AI approaches. And what's unique about some of these approaches, of course, is that they're real time, but then they're also available at large scale, because some of the platforms that we're tapping into are actually available at a global scale. And
what we've done in our collaborations with organizations like the WHO Hub have built technologies that mine the world's information about disease events. One example is a tool that we run called Health Map, which is very similar to other tools you may know, Medisys or GFIN, that tap into the world's information about disease events and uses that information to provide early warning about a particular event in a population. This is event-based surveillance, of course. And we use what we call natural language processing to organize all that information and take that massive amount of free text that is out there and organize it across disease and location and species. Now, of course, with the advent of generative AI, these types of tasks are incredibly simple. You put in an article into ChatGPT, you can get all that structure within seconds. You don't have to build a particular public health algorithm to do this kind of work. But of course, even if you did, this is technology that is not new. It's been used now for, as I mentioned, over a decade to take all that text, say an event about a typhoid outbreak in a part of India, and as a news event or a blog post or an astute clinician that posts this somewhere, you could take that text and then organize it, structure it, and then all of a sudden create a surveillance system that is really focused on providing the world's sort of heat map about disease events and populations. Now, Health Map is just one example of the use of AI, but it highlights the fact that we're already well underway in using these technologies. So while people may think in the audience that we don't have enough information to use AI, it's actually been part of the fabric of public health surveillance for quite some time. Of course, used to identify the earliest signs of COVID in China in 2019 through the mining of that information, all the way to providing a global view of what was happening with COVID in real time by mining all the world's information about the disease event, categorizing that information, and being able to provide in real time a situational view of what was happening with the pandemic. That was really unique because that is not kind of technology that was necessarily clearly available in real time prior to the pandemic. Now, it's really important to understand what the value of these technologies AI have to actually rubber meets the road impact and response. And yeah, it's easy to create a pretty map of AI generated dots, but what does this actually mean for a response? So I work in a pediatric hospital. We dealt with something what we termed the triple-demic, the impact of RSV, COVID, and flu simultaneously last season. And our systems were not designed to understand or the control for the impact of these three viruses simultaneously. We also didn't have forecasting tools that really enabled us to understand what we needed to do about elective procedures. Yes, there's some level of modeling that we can do to predict what the impact would be in our pediatric population so we could forecast the bed needs in our population. So in fact, what we had to do is turn to public health data, spatial temporal models, local information, as well as forecast to create a machine learning model that actually allowed us to predict the impact of these viruses simultaneously on our pediatric population. And what was amazing is that through this effort, we were actually able to predict to the day when the peaks of RSV and flu would be at our hospital, and that was directly impacting the response to allocate bed availability for elective procedures. Now, we also have to account for the fact that we had other co-circulating pathogens. We had the wildfires from Canada, we had pollen, all these different impacts in our pediatric population that we can now model through these emerging technologies that allow us to make better decisions at a healthcare level. Now, I'm talking about it as a hospital, but it's very similar to how you might function as a public health department, taking all these data inputs and making forecasts based on this emerging technology. So again, efforts that actually exist today that were actually deployed using AI technology. Now, of course, over the last year, AI tools have really emerged, and that's very clear that we're seeing a very impactful shift in the availability. And we heard, of course, the idea that now everyone has access to these tools in a different way. Now, these are not, niche software developers that can develop against these tools. There's actually groups that anybody can develop tools on ChatGPT. And for a public health perspective, you can use it for communication and outreach. You can use it for tracking misinformation. You can look at it for sentiment analysis, as well on the clinical infectious disease side. You can support decision making. It can help on the administration front. The use cases are pretty phenomenal. And from our perspective, we've been applying generative AI to a technology we've been running over the last few years with support from the Rockefeller Foundation and Google, and now the Wellcome Trust, to actually think about how we bring in AI to support the collection of mass amounts of data about emerging infectious diseases in the first 100 days. We actually, Global.health is a technology that was used to comb the internet, official and unofficial sources together to create line lists of cases, the largest line list repository that was created for COVID and then for Mpox. But imagine you start connecting these technologies, these massive data sets to AI, the opportunities become pretty substantial. I just wanted to show a quick example of connecting our large data sets to actually the WHO's disease outbreak news, and in a very quick hack, created a ChatGPT-like interaction tool based on all the WHO data out there. So imagine you insert all the WHO data that you can find and then ask questions. Make me a map of cholera outbreaks by country, or show me a graph of flu outbreaks per year, or how many people have died from Ebola across all outbreaks. The questions you can ask in a ChatGPT style, in a matter of minutes, you can create a tool that is incredibly helpful, that can be querying your internal data sets, that can support you in your ability to do your day-to-day jobs. There's no reason why any particular one of these questions should take a day of analysis when all that data is available and can be used to fine-tune a large language model and ultimately support you as a co-pilot in your day-to-day work. And having trouble advancing the slides here. Okay. Obviously, the opportunities for large language models in infectious disease surveillance are pretty amazing. And that was a very quick example. But imagine you start putting in all the healthcare literature out there, all the trial data out there, even healthcare information from the EHR companies that have that data. And so you have general text from Wikipedia merged with clinical data, merged with scientific literature. The opportunities to actually create a large language model for public health that supports surveillance and response become pretty substantial and incredible. And I think that's where we're headed. I'm looking very much forward to the conversation that we're going to have about these technologies and where the promise is, because I know many people feel we're not there yet by the answers to the survey, but clearly these things are being done today. Of course, I can't have this talk without mentioning the double sword in public health. There is an arms race. There is a challenge that these tools might get out of whack, right? There's the use of these tools are in the hands of malicious actors that could help derail public health activities. And so we have to really think very carefully about the incorrect information that these tools are putting out, the confidence that we have in the models, the biases that they may exist. And we at Boston Children's have created a group that is focused specifically on the underlying bias and in the data sets that we're using to fine-tune our algorithms to make sure that we're not leaving certain populations behind. And of course, we can't have this conversation without talking about data privacy. And I'm sure my colleague Joanna will mention these topics as well. But that being said, it's not just about AI algorithm development. It's going to be about the stewardship of this information and the data coordination. And that's why I'm really happy that Chikwe is here with me, because of course, organizations like the WHO Hub are going to play more and more of an important role in the coordination of data and the ability to deploy algorithms fairly, effectively, and making sure that they're adequately vetted as we launch them into the public domain. So with that, I'll close and look forward to this discussion. Thank you so much.
Thanks, John. I'm sure there's a loud applause for you in the room, but we can't hear it from where we are. No, but it's really fascinating, and reminding us really that we're on a journey already, and AI really has been used already in many ways that we may not be immediately obvious to many of us, and the impact it's already having in clinical medicine and some of the work we've done together around line lists and all of that. So, but the excitement and anxiety about the future and what large language models can offer, both in terms of opportunities, but definitely also a few threats, and how we manage those intersections to get more good out of it. So I'm sure there are lots of questions for you. So let's see what colleagues have, and someone in the room will help me with this.
Jackie. Yep. Yep.
Mike.
Yep. They're just that we're just putting some lights on so we don't have an accident.
Thank you very much. John, one key question people are asking, and it goes back to something we were also talking about this morning, saying, is this going to result in further health inequalities? A concern about, how do you combat training models that are really focused on predominantly rich countries and apply them in lower resource settings, and also linked to equitable access, but also to the issue of privacy, a question about should public health agencies be in charge of its application in public health, not technology companies. So who should be in charge overall of how we do this? Lots relating to equitable access.
Yeah, you packed a lot of different questions in that one question. That's amazing. And these are all topics that we're grappling with as we deploy within our own institution and through the products we're developing. On one hand, you can make the case that we're putting all the content, say as a healthcare institution, we're a top pediatric hospital, we have incredible knowledge. Imagine putting that knowledge, those protocols, those decision support tools, and fine-tuning a large language model that means that best-in-class care and decision support isn't just offered in our one institution, but is now made available more broadly. So that's the in defense case, that actually these tools, as the cost goes down, as they become freely available, we're going to democratize best-in-class care. And in fact, we've done surveys here in the US, and we've actually found that there is more interest from minority communities and lower income communities for AI, because the existing care that they're receiving is not adequate. So there's that one hand. On the other hand, yes, absolutely, we have to make sure that the models that we're using, or the data that we're using to train the models, are representative of the populations that we're trying to serve. And in fact, that's why I mentioned in our organization, we actually have a data equity community committee that is actually thinking about both the data that is being used to train the models, as well as the model output, and is taking responsibility for that output. So this is a key part of essentially everything that we are doing as a healthcare system to make sure that there are the adequate guardrails in play. And of course, from a data privacy standpoint, this is why we're working with the AI companies specifically, and this is not a public health organization or an AI company that should be in charge of this. It's a collaboration. We're working with OpenAI, and I'm sure everybody's reading the news about some of the turbulent times there, but we are actually building an internal OpenAI instance for our own healthcare system, so we can put in a HIPAA-compliant manner, patient data, confidential information, and we're working hand in hand. And this is not dissimilar from how we've worked with tech companies in the past, whether it's Google or Apple or Amazon. This is about partnership. Public health will never have the resources that these companies will have, but these companies will never have both the insights, the knowledge, and the stamina for long-term use, commitment to public health. And so it's always been about a partnership between these organizations.
We leave those till after we've heard the second presentation, but that was the strong thrust of some of the early questions coming in. Back to you, Chikwe.
Yeah, thanks a lot. And I'm sure there are many more questions forming, and we'll get to them at the end maybe. But John, I think before we leave the screen, what's your one final thought you want to offer? This is probably the most significant development in our space.
Yes.
For years, right? And everyone says it will fundamentally change how we work. So what's your final thought on this before?
This is a generational change in technology. I think it's equivalent to the availability of the internet. It's equivalent to the availability of the mobile phone. And we know how those two technologies have had deep impacts on public health. I would say that in some ways, those technologies took a while before they were really adopted by public health. We tend to be a little bit more on the conservative front. So I would advocate for public health to be more on the front lines, and we need the adequate training and we need the stakeholders at the table as policy is being developed. I think we saw the concerns about government not having enough of a role. I think we see the healthcare sector more broadly having a deep impact on the direction that these companies are going. And I would advocate that public health try to have as much of a seat at the table and not wait for these technologies to mature, because we were talking, I mean, the change and the pace is going to be rapid. And if we don't have the knowledge to adequately deploy these tools, there will be groups that will be deploying tools that will be causing a lot of challenge for our groups. Misinformation, whether purposeful or not, will be a challenge. So we need to get up to speed very quickly, because this is happening very fast.
Yeah, thanks, John. I'm sure we'll get back to some of those at the end of the session. So, Mike, I'll pass it back to you, and then we'll reconvene after the next speaker.
Thank you, Chikwe, and thank you very much, John. And there was plenty of applause in the room, I can assure you. Chikwe, what John just said there's a huge leadership role, and I know you personally and your hub have got a lot of that on your shoulders, and I can't think of anybody better to do it. So, brilliant. Now, as I mentioned, I don't think we've ever had a criminologist talk to us before. Not that we're talking about criminal things here, but particularly your experience working in the high-level group and the other work that you do. So, Joe, please, would you give us your perspective on artificial intelligence?
Thank you very much, Mike. So I'd like to thank the organisers and Mike and Chikwe for the invitation to be here today. I'm from the European Union Agency for Fundamental Rights, which is much like ECDC and EMA. It's an agency of the EU. What we do is we undertake research, we collect data on the situation of fundamental rights in the EU as it impacts on different groups. And in the last 6-7 years or so, we've increasingly been looking at AI and digitalization. So our research ranges from looking at asylum and migration, through to inequality and discrimination, you name it. We look at it with respect to fundamental rights. We do large-scale surveys, sometimes of hundreds of thousands of people in the EU, and in-depth social legal research. And some of our work has addressed health. For example, we've looked at discrimination against specific populations in the EU, such as irregular migrants. I'll be talking about AI, about fundamental rights, from the perspective of the EU. And I'll make a few general points. And I've put my subheading under this plenary title, Where Health Meets Fundamental Rights and AI. And I'll make 3 general points in this regard. So the first thing I'm going to be talking about is the AI Act, the Artificial Intelligence Act, in the context of the EU and fundamental rights, and what does it, or what will it mean in relation to health? Those of you from the EU or who are working in the field of health in the EU will be hopefully familiar with existing sector-based legislation on medical devices in the field of health. I'll give you a quote here from the European Parliament's Research Service, which it noted something about these existing regulations on medical devices. It said this: because these regulations were derived at a time when AI was at an early stage in its development, many aspects specific to AI are not considered, such as continuous learning of AI models or the identification of algorithmic biases. But in reference to AI and health in the context of the EU, political agreement is expected potentially by the end of this year, if not the beginning of next year, on the final text of the EU's Artificial Intelligence Act. And this represents the world's first regional, hard law, horizontal legislation on artificial intelligence. Much like the GDPR, the General Data Protection Regulation, its impact on our lives will be huge, and its reach will extend beyond the EU. It's the first regional instrument of its kind to try and manage AI, if you like. It adopts a risk-based approach to categorize AI systems. Various iterations of the Act have referred to health-related AI systems as belonging to one of a number of groups according to risk. For example, a fitness or nutritional app would be typically low risk, whereas an AI-based system to determine dosage when it's using a particular algorithm and a medical device would be high risk potentially. So in the EU, as you might be aware, sectoral legislation in the field of health already imposes numerous requirements on operators, such as risk management systems and documentation. So alignment between the new AI Act when it comes into place and sectoral legislation in the field of health is critical to facilitate harmonization and legal certainty, but importantly, to ensure fundamental rights compliant and trustworthy AI in line with the human-centric AI that's at the heart of this new act. Now, the Fundamental Rights Agency, we've been working closely with the Directorate General Connect that holds the pen in drafting this act, and we've also been working closely with the Council of Europe. We're part of the EU's delegation with the Council of Europe that's drafting a new AI treaty for 47 countries that extends beyond the 27 of the EU member states. As the final text of the AI Act is currently being negotiated, we cannot say as yet exactly how healthcare will be referred to and categorized, that is, as high risk or not, with respect to public health. Therefore, watch this space. So where do fundamental rights fit in all this with respect to both existing EU law covering health and the proposed AI Act? Well, over the last 5-6 years or so, debates concerning the scope and application of AI have moved from a discussion predominantly focusing on ethics to one of legality with respect to fundamental rights compliance, and the AI Act is proof of it. In circles now, you used to hear 5-6 years ago only reference to ethics, and I was the only person talking about law, and then increasingly that has changed in recent years. And here I need to make reference to something that you've probably not heard of, and that's the Charter of Fundamental Rights of the EU. It's a charter that is little known outside of legal circles. It applies to all EU regulations and directives, including those that cover health, and it will apply to the new AI Act. It is the EU's Bill of Rights, if you like. It contains 54 articles. Some relate to human dignity, the right to life, integrity of the person, freedom of expression, and there's one article specifically on healthcare. Increasingly, it's been used by national courts and the European Court of Justice, so if you don't comply with the Charter, you could end up with a court case. To reiterate, the Charter, and therefore fundamental rights, applies to all existing and new EU law, but at present there is a lack of clarity with respect to how fundamental rights compliance, as referred to in the forthcoming AI Act, including in reference to carrying out fundamental rights impact assessments, will be implemented in practice. And that applies also for where health will sit within the terms of this Act. So there's a lack of awareness of many actors of what fundamental rights encompass in practice, and this is what we saw in some of the Slido results just earlier. So this brings me to my second point, and I'll be very brief as I go forward now. I'll give one example in relation to FRA's research on AI. We've done quite a bit of research on AI, but just one example to illustrate what I mean in terms of knowledge gaps on fundamental rights. We published a report called Getting the Future Right in 2020, and for this report we interviewed 91 developers of AI and also deployers in the AI field, so 91 in total across 5 member states. They represented fields from social benefits, predictive policing, targeted advertising, and the health services. And we asked about them a series of questions to them about the kind of assessments they conducted when using AI and their awareness of fundamental rights. And we didn't give them leading questions. It's clear from the findings that extensive training is needed on what to look for with respect to fundamental rights compliance of AI systems. What did we find? Well, we found that when we asked about impact assessments, interviewees talked about technical impact assessments, compliance with the medical devices regulation, for example. They never referred to fundamental rights. When we asked about fundamental rights compliance, they did know about data protection because of GDPR. They knew a little bit about non-discrimination, but nobody mentioned the right to redress. Not a single interviewee of the 91 we talked to referred to the rights of the child at all. Also among interviewees, there was confusion regarding how to ensure non-discrimination. For example, many of them thought that by omitting information about protected characteristics or attributes, you would guarantee non-discrimination. They were not thinking about the use of proxies that also can highlight perhaps people's background. And what else can we say? Well, in terms of automated decision-making and the right to human review, there was a high level of uncertainty and clarity concerning the meaning of these terms. And more guidance is clearly needed on the application also of data protection, even though we have the General Data Protection Regulation. You all know about it every time you open up your smartphone. So really, it's very clear that people are very uncertain about the application of fundamental rights that go beyond data protection in practice. And this includes people we interviewed in the field of health. In sum, the report we undertook identified several gaps in developers' and deployers' knowledge concerning fundamental rights implications for using AI. And this brings me to my third point, which is AI for good, but only if we address the bad. So that we know there are news items practically every day and weekly about how AI is positive in terms of promoting our well-being and health, and it is. We can see huge positive developments in this regard. I was at a meeting last week in Madrid on AI, and there was a lot of presentations about AI and uses in cardiology, for example, and other examples. But what if something goes wrong? What if you are refused a drug because the data, the algorithm, denies access? What are your rights to redress if you are denied access? Or what about when the algorithm has been using proxies in its data sets that form the basis of that AI system? Proxies such as your height, which might indicate within a certain population your sex, or the food choices you make in hospital could determine perhaps your religious background. Are people also thinking about how deep some of these issues go in terms of fundamental rights compliance? And at the heart of these concerns lies essentially trustworthy AI. That is, public trust in how the state and private entities are using their data. One of the surveys that the Fundamental Rights conducted was amongst 35,000 people across the EU about the experience of fundamental rights in practice. And within it, we had some questions about willingness to share personal data with public administration or with private companies. And we asked about willingness to share facial images and also fingerprint scans for various purposes. And less than 1 in 20, for example, were willing to share fingerprint scans, and also 6% were willing to share their facial image. And the results vary strongly between countries. Trust in the state, if you look at the EU 27, varies enormously between the countries and between the individuals you speak to. So why am I making this point? Well, this reflects levels of trust across different countries and different groups within countries for sharing personal sensitive data, including data on one's health, which impacts on both the public and the private sector and how they gather that data. And it reflects real concerns about how data is collected and used to develop AI systems in the field of health, both inside and outside the EU, which is a core fundamental rights consideration. So, what to do to ensure fundamental rights compliance in the field of health and AI? Well, the European Commission's high-level expert group on AI, which I was a member of, produced guidelines for trustworthy AI, which relate to 7 core components. For example, human agency and oversight. Another one, societal and environmental well-being. Another, diversity, non-discrimination, and fairness. And these were drilled down with practical examples of how to apply these. In turn, the European Parliament has proposed that deployers of high-risk AI systems have to carry out a fundamental rights impact assessment before a high-risk system is put into use within the draft AI Act. There are some examples of what such a fundamental rights impact assessment might contain. For example, it says things like the reasonably foreseeable impact on fundamental rights of putting the high-risk AI system into use, specific risks of harm likely to impact marginalized persons or other groups. Fundamental rights are embedded within the draft AI Act and encompass all stages of an AI system's life cycle with respect to trustworthy AI. And what the final draft will look like, we cannot say. However, very practical questions remain, which are relevant to all sectors when using AI, including health. I'll take one example and then I'll finish. So how can we address discrimination with respect to AI and the data it uses? There is a clear need for enhanced transparency and accountability concerning data and potential bias, the point that was raised in that question earlier. Collecting sensitive data to identify and mitigate against bias is welcome. It is a proposed article in the AI Act. It says you can collect sensitive data to try and mitigate bias, but you have to do this in full compliance with the law, of course. An independent external oversight using experts in the field of discrimination, for example, from the EU's equality bodies would be an important step. So to conclude, AI for good, if it is essentially human-centric and built on trust, mirrors fundamental rights principles. The do no harm principle speaks to both disciplines of health and fundamental rights, and with this in mind, we can look for synergies. And with that, I'll leave you with a list of some of the publications that the Fundamental Rights has done on AI, but the general principles in all our publications apply across all sectors, not only health, but all sectors of life. And I refer to the Getting the Future Right report there in my intervention. Thank you very much.
Joanna, thank you so much. I've looked to Jackie to see if there are any burning questions there, but can I just add, I think I completely agree with Chikwe that the publication that John also referred to in his presentation is essential reading in this, but I would also suggest that the report of the high-level group is also essential reading in this, the high-level group on AI, the European Commission group. Jackie.
Thank you very much. A couple of specific questions, lots of questions still relating to discrimination and bias. John touched on it, Joanna mentioned it there. I don't know whether you can elaborate more. There's a lot of concern about bias in the data. But one specific question to you, and then there are lots of broader ones, Mike, to take later on. But Joanna, can you give an example, a questioner asks, of what impact the AI Act could have beyond the European Union? So we're operating in a global context here. I think that concern, if we only focus on the impact within Europe.
Okay, so I mentioned quite a bit GDPR, General Data Protection Regulation, which all of us, every time we open up an app, we have to consent, not knowing what we're consenting to necessarily. That has impact on business and industry globally if they want to work with the EU. With the AI Act, because it is the first regional instrument of its kind and globally the first instrument of its kind in terms of hardcore law, once it comes into place, into being, its impact, if you want to do business and use AI systems in the EU, beyond the EU, its reach will be huge.
Thank you very much. In a broader sense, Mike, if you want to move on to that, we've got questions around costs, questions around data quality and interpretation, and questions around ownership. Do you want to take a few of those now, or?
I think that what we should do is we'll look at some of the key things for us, and one of them is around AI and surveillance. And Chikwe, can we see if we've got questions that relate to AI and surveillance? And Chikwe, perhaps I can look to you to lead this bit, and then see if you've got any suggestions to prompt some good questions on this.
Yeah, while we're waiting for some to come in from the audience, John, why don't we start generally on surveillance and to think, ultimately what we do in surveillance, or what we try to do, is to drive decision making, and hopefully drive it enable decision making, hopefully enable it in the right direction, right? Are there any examples already of how you see that happening within the last few years, and improving and changing, that you can share?
Well, I mean, there are great examples. I would say, I highlighted some of the work of event-based surveillance. I would especially call out the work of EIOS and the work that they've been doing to organize content across many different surveillance systems. Part of the challenge is that we're dealing with a mosaic of technologies that are providing situational awareness, all with their different features, sensitivity, specificity, timeliness. And part of the work, of course, to organize that requires a machine learning approach to organize all that information and help support response. And so I think, our job as system developers are to provide best-in-class data, but organizing that content so that hubs of information focus can support their work. So that's one example. I would say very specifically the AI work that we've been doing to monitor population sentiment was also really key during the pandemic. One of the challenges, of course, is that we were launching vaccines into population. This was especially true in the US, where there was challenges in vaccine confidence. And using the tools that we've been developed to mine online conversations and chatters, we were able to get detailed information about rumors, attitudes, and beliefs, and help support US CDC in making decisions about how to think about vaccine deployment. We know, for instance, that the J&J vaccine got hit with a drop in confidence because of a pause, and that we could identify that in real time based on some of this data mining, and that helped rethink how to tune messaging that was coming across about each of the different vaccines. We also know this was true during the deployment of masking, especially again in the US, where there was a lot of pushback. And so understanding where the lack of understanding and awareness and the scientific basis for masking was coming was super helpful in the response. So it's not just about early detection of events, but it was also in assessment of the attitudes and beliefs and acceptance of different public health interventions.
Yeah, thanks for that. And really to invite colleagues in the room and online, any questions, comments, please send them in, your experience. Maybe Jackie, you have a few already. Do you want to share some?
Delay on the connection. One specific question, and it links to this question of data ownership, which we were talking about earlier. People saying, how freely available is this data that will be scraped for these potential analyses of early detection and surveillance? And what would the impact of limits being put on data scraping? We've seen that, for example, with X. In terms of the potential uses of AI for early signal detection. And also a very specific question to you, John. When AI is used for outbreak signal detection, do they also work prospectively? Because, says the questioner, identifying signals in the past is one thing, but identifying them in real time without too many false alarms is really something else. Yeah. So too specific to surveillance and early detection.
Yeah, great questions.
Why don't you start, John, and then Go ahead.
No, absolutely. So the tools that we've been developing all have been about prospective surveillance. They, of course, you can always look back in data and decide that you could see the signal, but all the work that we were talking about was absolutely prospective in nature. The mining of these data sources, news, social media, they all are active surveillance systems that are providing signals, as I mentioned, for instance, to colleagues at EIOS at the WHO and CDC and many others. The challenges of data availability from tech partners is something very serious. We relied on Twitter data as a source of information for a decade, and then quickly got that stopped. And so that is a challenge. All the systems that we develop, the information is openly available, accessible. Some of the raw data, yes, we have to figure out developing very unique relationships with to access that data. And as soon as a technology changes, we get into trouble because we get our access changed. So X is an example. Facebook had the largest global survey that was incredibly valuable during the pandemic because it really supplemented for traditional surveillance, syndromic surveillance, as well as attitudes and beliefs in the population. They ended that because of lack of funding. So this is an absolute challenge that we are facing when we're so dependent on some of the tech companies. At the same time, it's almost impossible for us to recreate any of those technologies as a public health organization. We're not going to create a Twitter-like technology or Facebook technology. So we have to keep moving forward, working with tech companies that are willing to work with us to provide us this kind of data, but we're going to have to recognize that these data sources can be transient, even if we've been depending on them for many years.
Joanna, do you want to comment on that in the terms of the safeguards?
Well, I think some of the safeguards that will be coming in, I mean, as I said, they apply to the field of health and all fields. When we're talking about fundamental rights impact assessments, we have to see where this will land with the AI Act in the coming weeks, and whether high-risk public health applications of AI will be encompassed within that. If they are, of course, all the transparency and accountability about the data sources will have to be very upfront. I think the debate that was there a few years ago about self-assessment is problematic. You had the tech companies and other actors saying, no, we can take care of our data, we can clean it, we can make sure it's not biased, and we can do that through self-assessment. We don't need any regulation in that regard. So I think that is very much, the approach to that has changed very much in the EU. So if we're talking about the data and getting access to data, scraping data from the web, getting good data though, if you're thinking about having the right checks and balances and with the right experts in place who understand what good data is and how to mitigate against bias, this is a welcome development. I mentioned also that there's an article in this draft AI Act that says you can collect sensitive data to try and identify bias in your data set. And that is actually using that then to say, well, you collect sensitive data, you identify bias and you correct. So you get better data. So there are very positive things when you look in that act, if those articles stay there, that can only improve the quality of the data, the modeling and what you get from it.
I think that we've heard some excellent talks from John and from Joe. At the top of this session, we asked if there were things, we asked about whether you had the skills and the knowledge to make use of AI. Now, you've heard a lot today about the technical opportunities and the things that John was talking about, but also heard about not just the ethics, but the legal framework within which it's going to work. So I just wonder, are there questions, you have specific questions are related to what you think, what skills you think we need, where our knowledge might most be lacking? And I don't know whether, Jackie, there were any questions of that.
There was one basically just in terms of what impact all of this should have on the training of public health officials. A lot of questions around that and around having the capacity to validate this information and to respond. Is it commensurate with the signals that we're getting generated by AI? So lots of concerns about the training and about the human capacity to deal with all of this.
Actually, Chikwe, can I turn to you, because your hub has got a key role here, and I'd be interested. I think the audience would be interested to hear your thoughts on the training and what your particular organisation is doing there.
Yeah, thanks, Mike. This is a space that is really still evolving, and what we're doing at the moment is convening colleagues like John to help us shape that space. It's not a space where I can say within the organization we have all the expertise that we need. We do have some, and colleagues that have been working on this for a while, but this is really a space where we will have to work with colleagues, firstly to define exactly what we need to be trained on, and then to think about how to do it together. But I also think that the training in this space I don't think it will go through the conventional kind of modular form of training that we're used to, because the space just evolves too quickly. So we will have to really think ourselves of the concept of how we understand training in itself for a rapidly evolving field. John, we've had some conversations on this. Do you want to reflect on this a bit?
Yeah, absolutely. I'm happy to. I mean, we have, this is a challenge because what we're trying to do within our own institution is we're trying to level everyone up to these tools. But clearly, not everyone is going to need to have the technical training in developing an AI bot. But out of the gate, these tools are pretty straightforward. But we have to know their limitations, the guardrails in the use, what they can be used for, what they shouldn't be used for. So on one hand, we're building up that technical capacity in our organization. We've actually hired the first prompt engineer in healthcare. And if people don't know what that is essentially someone who actually has expertise in knowing how to query a large language model to get the most out of it. Of course, many people in the audience have probably used ChatGPT very, very rudimentary, in a rudimentary way to get insights. But the more complex the prompt is, the better the output. And so we've hired someone on our team that's actually helping craft those prompts and educating people how to engage with an AI to get it the most effective use. So on one hand, we're training people on how to use these tools. We've also created oversight committees and ways in which people can get access to these products, training efforts. It's a big lift. It's a big lift to get there. But we believe that the value on the other side of all that lift is worth it, because it's going to ultimately mean that people in our day-to-day jobs can do those things more effectively. And I think one of the things that I have to stress, because it comes up a lot, which is, these tools are not meant to replace the trained expert, the individual in their day-to-day job. It's really a co-pilot. Think about the massive amount of overhead in your day-to-day life, whether it's responding to emails or managing large data sets, repetitive tasks. This is where these technologies are going to play a real role. And now I'm sure Joanna has very specific views on how to do that responsibly, and I'm excited to hear what she has to say. But that the cat is out of the bag a little bit, and so our job is now to allow people to use these effectively and safely.
John was asked for your comments, and I think also from your experience as being on these various committees to talking people working in the health field and others, where do you think the priorities are in terms of skilling and learning?
Well, something that is talked about now is what we call AI legislative sandboxes. So, you sandbox ideas, you test the law, and this is what's happening in Spain at the moment. The Spanish government is doing this. And this allows for a safer environment, particularly to look at what we call high-risk AI system applications. So we're not talking about the low-risk AI like the chatbot, where it's a chatbot and you're just, you're asking it questions, it responds. We're talking about high-risk AI, which impacts in some areas of public health, but not other areas. So you sandbox things to test them out in a safe environment. That is happening. Also, you need to bring on board not only the technical experts who understand the right prompts, how to work with the data, but people who really understand, and I'll return to that one area of fundamental rights, discrimination and bias. Again, in the context of the European Union, you have bodies set up by EU law called equality bodies. Their everyday work is about looking at discrimination and bias in everyday life. So it's about that multidisciplinary approach. I know it's an easy word to throw out, but if you're looking to have ethical AI and legally compliant AI, go to other actors. I mean, I wonder how many medics know about the existence of equality bodies, maybe bringing them on board in the EU if you're discussing a particular high-risk AI that might be using highly sensitive data. So lots of other expert areas to bring in there, and equally people with a legal background, with a fundamental rights background, need to sit with those who are developing and deploying AI. The EU's high-level expert group on AI did this. They brought very, very different actors together, and I think that's the only way forward, because you don't want a standoff. You want to use AI for good, which of course is at the heart of health responses, and that's also reflecting what fundamental rights is about, AI for good.
Okay, Jackie, I think before we ask John and Joe to sort of give us their final thoughts on this, you mentioned we had a number of other questions. Are there any key questions that would be good to...
The really key issue, I think, for a lot of people relates to how do we know the generated information is correct? How do we ensure we don't lose the interpretive step, especially with regard to the quality of data, a concern about garbage in, garbage out? I mentioned the capacity issue. Do we need to set up some sort of quality assurance regarding the use of AI in public health? I think those are all the biggest concerns. It's the quality of the data and the capacity to interpret it.
Right. John, I saw that. Yeah, I could see from the facial expressions, you must have some thoughts on that.
No, I honestly, I just had a thought that all those questions make me realize that we may need a specific conference of escaide AI. Actually, AI is already in the acronym of escaide, so there's a potential, I don't know if that was predictive of your future when you set up escaide, that it was going to be an AI conference, but we may need a separate meeting because there was a lot to unpack in that. And I agree, a lot of the concerns about false information, we call that hallucination of these large language models. You cannot let these tools sort of run wild. That's why you need a human in the loop. And these tools are evolving. I think there's a recognition. If you look at some of the work that Google has done most recently, they're spending a lot of their resources to eliminate these hallucinations. But that is a major feature that currently exists. And so you can't just let these things go. From our perspective, we use these things to interpret our own data, or organize our own text, as opposed to use it for primary research. That's where I think some of these tools currently fall a little bit short, and you have to be very, very careful on their use. So, but I'm excited for escaide with a big AI in the middle for the next conference.
Absolutely, no, I like that. It struck me that throughout the presentations, the word bias has come up several times, and bias, of course, for us who in epidemiology is a really important topic. It's often hidden, it's sometimes very difficult to deal with, and it sounds like it's no different with AI. Chikwe, you wanted to say something.
No, we couldn't hear you for a moment, but just to say one final word, then you wrap up. It's just the speed of change in this space is so, it's almost impossible to keep up. So this is where communities like the one we have here will have to kind of shape our thinking in this space, because this is not an area we can rely on one expert somewhere in the world to guide us through. We'll really need the entire community to pull this, to shape how we engage on this in the work that we're doing. Back to you, Mike.
Okay, so I think, Joe, final message for the audience here. What's a key take-home that you would...
So hopefully the message I did get across is that there's a new kid on the block in terms of an AI Act for the EU. It will have huge implications, and we have to watch this space with respect to how it will impact in certain areas of health that are high risk. And you might find in a few years you're going to have to do fundamental rights impact assessments, but do it with good humor, because it's doing it with the same principle of medicine for good, AI for good.
Thank you. Chikwe?
No, thanks, Mike. I look really forward to engaging with this. The number of participants in this conference is always, both inspiring and challenging. But I remember ending this way. My father-in-law, who said, when he was working at the time, computers were being introduced into his work environment, and he tried to get out quickly enough so that he did not have to learn this whole new area. So, and this is the question I think many colleagues are asking: how much do we need to reskill and rethink fundamentally about our work, given the new opportunities? And we need to overcome our anxiety and move forward with this.
Yep. So I'd like to thank our speakers, thank my fellow chair, Chikwe, and I think that I found this absolutely fascinating. And actually, John, please. And John, in all seriousness, you made the comment about escaide. And I get the sense that we almost do need a European scientific conference on the application of AI for disease control and prevention. We may have to play around with it, but to me, it provided some answers, it provided some vision, but it also asked lots of questions. And this is a discussion that is going to run. But I think we've been given a fantastic grounding in the opportunities where the technology is, the challenges, and the fact that there's going to be a new legal framework that we will need to work within. So thank you, everybody. Great session, and I think we now will be moving on to the wrap-up. Is that right?
Thank you.